My name is Melissa Mertz. I am a nurse practitioner. I have started CR Family Practice here in Three Rivers with Dr. William Roach, and we have a professional corporation which serves as primary care for citizens in Three Rivers and the surrounding mountain communities. We will be seeing patients from birth to death. That means 0 to over 100. And when I say we, I actually do mean myself. If I am not here, I will hopefully have someone to cover me, but the patients will be seeing myself. I grew up in southern Idaho. My parents actually grew up in Los Angeles and decided they did not want to raise their children in Los Angeles. So my mother went to nursing school in Idaho, and I spent all of my summers in Southern California because of my grandparents. So needless to say, my mother was not pleased when I decided to move from Idaho to Southern California. But I did live there for many years, where I met my husband, Mark Mertz. We met in grad school at USC for a Master's of Health Administration program. And I ended up coming to Three Rivers because Mark and I were looking for somewhere maybe for retirement, something for the future. We wanted something that we could drive to, and I had family that lived in Three Rivers, so I brought that up to him. And we came, I showed him the community, so we decided to buy a place that maybe we would live in many years from then. It turns out after 3 years of coming up every single weekend, every vacation, every holiday, we were stuck. We were not going anywhere, so we decided to stay in Three Rivers. Stuck's the wrong word, I will say. We were, we definitely became part of the community, and we fell in love with the area, and we loved our home. So once we moved here, I worked for Family Healthcare Network for 6 years, as many people know me from. My husband has worked for the hospital during that time. And we have really grown into, I would say, ranchers and farmers. We've really grown into the natural part of the community. We now have 5 cattle. We have 2 horses. I have 3 mini donkeys and 2 mini horses. So we have loved having our livestock. That has really kept us busy most of the day. So if anyone asks us if we have any hobbies, pretty much taking care of the ranch and taking care of our animals is our hobby. We spend our afternoons or our mornings working, and then we spend the afternoons relaxing. Often we'll be in the pastures with the littles, as I call them, and we get pets and loves and have fun and take photos and videos, and it's a lot of work, but we really love it. And actually one time we laughed when we were fixing fences. We laughed, what do other people do on the weekends for fun? Because that's all we ever do is work on the property. But I think most people around here really understand where we're coming from. I went into the medical field primarily because it was something that I wanted since I was 5 years old. I don't remember a time when I did not want to be in medicine, or at least in some form. I come from a family of nurses. My grandmother was a critical care nurse. My mother was an ICU nurse. My aunt is a PICU nurse. And even my grandmother's sister was a nurse. So if I did not go into nursing, it would have been against my genetics. So I think I was born to be in nursing, but I did feel that I was better suited for the provider role compared to some of my classmates, and so that's the avenue that I went. When I graduated my undergrad, I worked in cancer research I worked at USC Norris Cancer Hospital for over 15 years. Much of that was either breast cancer or colorectal GI cancers. So I've always been in medicine in some form, whether through research or nursing or now as a nurse practitioner. My thought for opening the pharmacy and clinic in Three Rivers was really twofold. One was I needed it for me. I needed something different for me. Working in my previous clinic was very difficult. I loved it. I loved my patients and I loved my coworkers, but I was seeing 34 or more patients per day, and I got to the point where I did not feel that I could do a good job of taking care of myself or taking care of my patients. So in the end, none of us were winning. The patients were getting the care. I wasn't getting my own self-care. So before the pharmacy closed, actually, my husband did say, hey, why don't you open your own clinic? That would be something you can do. So I decided, well, okay, I can do that. And a couple days later, I called him up and told him I put an offer on a building. And that was a little fast, I think, but we got through it. So the day that I closed the escrow was 2 days before the pharmacy closed. And that was devastating. As a provider, it was very hard for the patients, for myself, and I know it was devastating for the community. So right away, I knew that that was what I wanted to put in my building. I knew I wouldn't use all of the space for myself, but that I could use a part, and rather than have it as a retail space, I could try to convert part of that to a pharmacy. Now, I do want to say this, David Stanley, I know people were upset that it closed suddenly, but I understand where he was coming from. When you do something like that, where you sell something from a medical standpoint, a pharmacy, the sale can only go through if there is, well, the data. The data is what is for sale. So if he were to tell someone ahead of time, then that wouldn't go through. So I just want people to understand, I'm not blaming David for any of the pharmacy closing at all. That's how these things work. But I was very happy to be able to have space in this building. Initially, I did want it to be a nonprofit for myself, and then it did turn out that I couldn't have the pharmacy and my practice in the same nonprofit because I'm a prescribing provider. So then I did have to branch out, and now we had two. So I have a private board for the pharmacy, and then I have my own professional corporation with Dr. Roach. So the clinic is really having a soft opening, and this has to do with Medicare contracting. Now that I have a Medicare license, which I just received, which is amazing, we can work on other private insurance contracts, and we can also now work on the Medi-Cal application. So what that means is at this current time, I will be open for Medicare. There are two types of Medicare. There are Medicare with supplemental. Some people with Medicare don't have supplemental, or there's Medicare Advantage. So I want to show you the cards just so that can be of assistance. If anyone has this little red, white, and blue card, this is the Medicare card, and anyone that has this card is who I can see right now. I will put the phone number for appointments, and we can get people scheduled right away. Now, if you have a supplemental card, that's okay. I can still see you, and I'll be seeing you at the same price that you would be otherwise. Now, if you have the other type of card, which is the Medicare Advantage card, that does come a little bit later, unfortunately. Also, that goes for the Medi-Cal patients. Now, for private patients, I can see key medical patients that are HMO, We're working on the PPO contracts, and I can also see Aetna patients. So we're working on them. It's a rolling process, unfortunately. So I don't have an actual date to when I can be open fully to see all patients. It could be a couple of months, it could be several, 4 to 6 months. I have no way of knowing, but I will at least now be able to be open so that I can answer those questions. I know it's been frustrating because there has been a lot of up in the air, and unfortunately it's because I don't have those answers. I will have some staff coming. I have Nicole starting next week, and then I have another medical assistant starting in April. So once I have more staff in place, that will also make it easier for patients to get scheduled, get on the schedule, and come see me. Now, we do plan to offer lab services like we did before at the other clinic. So the opening of the pharmacy has everything to do with the California Board of Pharmacy. We have submitted the application. We are waiting for them to see if our reason for opening a pharmacy is compelling enough. Of course, those of us in the community rightly think that we are. We are fairly isolated. We have to drive over 20 miles to get to the next pharmacy, and we have a lake to drive around, and not everyone can drive around the lake. So we anticipate that our application will be approved sometime in May. So hopefully we can open in June. So while I am saying that I'm open now and I'm having a soft opening, I will do a grand opening when we have an opening date for the pharmacy. So the building will be open to anyone and everyone. We will have a little soiree. Everyone can come see what the pharmacy will look like. Of course, it won't be stocked. And then that will be about 2 weeks after that when the pharmacy will actually open to residents. So eventually in the clinic, it will be a full primary care practice. I will have an EKG machine. Of course, we will take vital signs with blood pressure. We will have a lot of, we call it point of service testing. So I will be able to test for the A1C. I will be doing all of the cough, cold, upper respiratory illness like RSV, COVID, flu, strep. I have a machine called ID Now, which is the best on the market, and it's the same one that's used in the emergency room, so I'm very excited about that. I will be offering lab, as I mentioned. We will do the services for patients who are our patients. Now, let's say someone needs labs for a specialist. If we have ordered that specialist, then we will draw those labs whenever the patient needs to come back. If it's a patient that is not my patient but still wants blood drawn, that's absolutely fine too. What we have them do is we have a visit so that I can document, enter the labs, and then we will draw the blood and send them to the pharmacy. And that was the same policy that we had over at the other clinic as well. Referrals will happen like this. When a patient has a need or a request, I will put it in my electronic medical record, and one of the staff will process that. What that means is it would be in any network that is within your insurance. So for example, if you had Humana, we could only send you to the doctors that Humana had. So we would process them, get the approval through Humana, and then send them to that specialist. Sometimes with, say, like Medicare doesn't need an authorization. So then I would send them to a physician or specialist that I thought was, I would say, a good one in their area. Now, what happens is when you're a private doctor, you don't have, let's necessarily a network. So within Family Healthcare Network, maybe I would choose the Family Healthcare Network doctors, and I don't have that. What I do is I choose the doctors that I know, that I have relationship with, that I feel take good care of my patients. And then otherwise, we defer to the specialists that are within the insurance network. Because of course, we want patients to have their services covered. So in general, we will be processing them according to however the insurance prefers. And then if there is no preference with the insurance, either the patient or myself can decide who we think is the best option. Good question. I would like to be able to offer some after hours. Our hours of operation will be 8 to 4:30. 4:30 will likely be the last patient, 4:15 to 4:30, Monday through Thursday, and Fridays 8 to 3. I do hope to be able to have a lot of walk-ins, and for after hours, it's not going to start immediately. I would like to have a nurse line where people can call in and have triage. So the triage nurse would be able to say, that's an emergency, you need to go to the emergency room, or they could say that's something that you can treat at home in this way, or they would say this is fine, we'll make an appointment, then you can see the doctor tomorrow. Now that isn't going to happen immediately. Those type of services do cost extra money that I have to be able to make sure is within my budget. In general, the services will be the same. I can think of one or two things that I will be offering here that they are not able to offer there. Some of those things are the testing that I'm able to offer. In general, it will be very much the same. It's a primary care practice with some walk-ins. We'll do the wellness visits, annual physicals, labs, immunizations, and then the acute visits. At Family Healthcare Network and here at this office, if we need to send someone for any imaging, it has to be down in Visalia. Now, what I hope that I can offer differently is speed of processing for referrals. I know before I left Family Healthcare Network, they had something incredible, like 20,000 referrals that were in arrears. That won't happen because I won't see that many patients, but I also hope that, with my staff, we can keep up with that processing. The other thing is the telephones. I know that the telephones had gone away from Family Healthcare Network, and I will say part of that was a double-edged sword. I think having phones was really hard on the staff because people would want to get attention immediately, and that's understandable when you don't feel good or when it feels like an emergency. But what would happen is people would call and hang up because they didn't want to wait on hold. So eventually the phones left. I am working with the staff. We're trying to come up with ways to make it easier on patients and the staff. So we will have a texting line. I have a phone system that as soon as you leave a message on the answering machine, it sends an email to the staff. So we'll be constantly seeing that. So people don't have to call and hang up. They don't have to leave several messages. Know that we did get the message and we will try to get to it as soon as possible. So we'll be working on that with patients. So they cannot take over the accounts directly. It's not one of these things where we can go to Rite-Aid and Woodlake and say we would like those accounts back. What has to happen is patients will come to the pharmacy. Our pharmacist will call Rite-Aid and have those prescriptions transferred, and that's how that works. The pharmacy and the office will offer vaccines. We don't have this worked out yet because I don't have a pharmacy to work with, but I'm hoping that we can either share the vaccine load, or that way one of us can offer the majority and then the pharmacy offers some. It might end up being that we both offer the same things. We don't know exactly how that will look, but both sides will offer vaccines. So the office is not part of a network in that we are part of CUIA or part of a federally qualified health clinic like Family Healthcare Network. We are private, standalone. What that means is for every single insurance that we take, we have to establish a contract. And unfortunately, that's what has been taking so long for me to be open and see all of the patients that I want to see. But as a private office, we will be reaching out to as many insurance contracts as possible. That means all of the ones that we're seeing at Family Healthcare Network, plus the Humana and the Key Medical. There are a few that are for travelers that we'll also be taking, but these things will take time. As I said before, I don't know exactly when they will all be approved, but we are working on them actively right now. As far as the pharmacy, again, it is going to be a private pharmacy. So the pharmacy is not within a network of any kind. However, we will be contracting with insurances to be able to offer the pharmacy services. Now, I'm really hoping that we will be able to get some of the mail order pharmacy contracts. So instead of patients having to go to the mailbox, you could come here. But again, that's one of those things that those types of contracts will take time. We will absolutely be able to cater to international and out-of-state patients. What we do is either we bill them directly or we go through their insurance. We will be able to have access to a lot of the networks, the insurance networks that are with other states. And I will also be offering a sliding scale for those who do not have insurance or who do not have any type of coverage. So there will be that option as well. I do have a website, sierrafamilypractice.com, that has a lot of the services. It does not have anything about rates. Rates, unfortunately, is a very subjective, very hard thing to nail down because of the insurance. One insurance might pay me $10 for a service and another might pay me $35. So there's not any way for me to advertise my rates, but I do have a website with services, and I do think it's a good idea that I will update my Facebook page as well. Of course, people will be able to call in shortly as the phone lines are coming online, and now that we'll be more staffed, hopefully I can have staff and some answers in the building itself. I invite anyone who wants to come start paperwork. They may come now. I know I advertised it a little bit early because I thought I would have everything done, but unfortunately it wasn't on Monday, but today, Tuesday, I do have paperwork. So anyone can come to the building from 8 to 4:30 and we will have packets. Oh, I do need to say we are closed from 12 to 1. I love the idea of offering well visits for non-mobile Three Rivers residents. I think that healthcare is something that everyone needs, and just because someone can't make it physically to the office, I will love to do some home visits for patients who are unable. The thing about a primary care office is there are a lot of things that we can and should be doing. One of those is being a medical home. So that means that we are a facility that keeps track of your medications, that we know what surgeries you've had, what specialists you're seeing, so that way things aren't duplicated, and that means medications aren't being prescribed and maybe duplicated, which might cause a dangerous reaction. So this being a primary care office should be considered a medical home. What that means is if you've been to the specialist, then we can do your follow-ups here. If you, say for example, had a Mohs procedure and it's a 2-hour drive, I can always remove sutures in clinic or in office here, take photos, and speak with the specialist. That goes for any type of specialty. I really love the idea of coordinated care, and that's what a medical home should do, coordinate care. So maybe it seems that a doctor maybe isn't doing much, or let's say if you go to the nephrologist, this is one thing I hear, well, I went to the nephrologist and they didn't do anything. Well, having a follow-up with me, we kind of put all of the data together and explain what the nephrologist really did was review the labs, make sure everything is healthy, make sure that you don't need to be on dialysis. So while it didn't feel or appear that a lot was done, really it was a lot to make sure that you're at least in the same stable space. So sometimes a visit might just be going over medications and vital signs. Other times they're for falls or emergent things. But in this office, we hope to be able to accommodate all of those things. If a patient has to go to a specialist, if I've referred them, or even if another specialist has referred them, if I am the medical home, if I'm the practitioner that helps keep you going in all of your medical appointments and medications, then I would be considered the PCP, the primary care provider. So I would say that I acknowledge that some patients do not want a nurse practitioner as their primary care provider. And that is absolutely anyone's right. And I don't begrudge anyone who prefers to have the doctor as their PCP. I do the same function, and I do appreciate that I have primary care physicians that I can reach out to if ever I have questions. I have several colleagues that are doctors that I can consult with. And of course, if ever I'm not sure, that goes to the specialist as well. So the reason for filling out someone as a primary care physician is so that the information comes back to us, so that, again, we can keep that information in your medical home. So we can keep all of your health information in one place. And then if it's ever needed, it's in a nice little binder where you can present it to a specialist or the hospital, whatever is needed. So I love the idea of elder and senior care, and some of that we already do, and some of that I do want to expand. Of course, I will be doing all of the beloved annual wellness visits through Medicare, so we will be offering those. I would like the chronic care management to be part of the relationship with the pharmacist. So what that would mean is you would have an appointment with the pharmacist maybe once every 3 to 6 months to go over the medications. Maybe there's something that they've missed, that they catch that I have missed, because they are very smart, very knowledgeable in all of these medications. So I would love that in part of the senior care. And I also feel that part of senior care is frequent visits. And sometimes those visits aren't necessarily, doctor visits because you have something wrong, but sometimes it's because maybe we need to find out what's going on in your life, and has anything changed recently, and are there any falls? So I feel like the senior visits are really all encompassing of really all the visits that we do here. I have always been on the idea of treating the whole person, not just a symptom. So I don't ever think that you can look at someone in a vacuum and say, well, here's your symptom that's related to your heart and it's not related to other things. No, everything is related to the whole person. I think I've been on the spot enough, but I appreciate the ability to do this. I appreciate Three Rivers and serving the community.